I am going to introduce to you some modern concepts about the treatment of Chiari malformation and syringomyelia. If you realize, the subject of Chiari malformation and syringomyelia both have been studied for over 150 years. The general understanding of Chiari malformation and syringomyelia are that both of these anomalies are congenital malformation or errors in formation. In Chiari malformation, the tonsils, the cerebellar tonsil herniates down into the foramen magnum and into the spine. The concept is that this herniation is related to decrease in the volume of the posterior cranial fossa where lies the cerebellar hemisphere. According to this concept that the posterior cranial fossa volume is reduced, we had also analyzed and evaluated and come to the conclusion that foramen magnum decompression is the treatment, or posterior fossa volume expansion is the treatment. So the cause of the problem is reduction in the posterior cranial fossa volume. That is why the excessive tonsil herniates down into the foramen magnum, and the need of treatment is expansion of the foramen magnum or posterior cranial fossa volume. That is the treatment. Many a times, Chiari malformation is associated with basilar invagination or bone malformations in the region of the craniovertebral junction. As we mature, as we develop in our understanding of Chiari malformation, in our understanding of syringomyelia, in the understanding of basilar invagination, we have come to a very fantastic conclusion that all these problems are not primary or not related to embryological issues. They are related to one problem, and that problem is atlantoaxial instability. We have also come to a conclusion that Chiari malformation or tonsillar herniation is not a problem. It is a divine intervention or a solution. It is like nature's airbag which is introduced into the foramen magnum with the intention of protection or providing a cushion to the cord in the presence of manifest or potential atlantoaxial instability. So we have introduced a concept of central or axial atlantoaxial instability. In this concept states that this instability may not be demonstrated radiologically by dynamic imaging, or may not be demonstrated by conventional form of understanding by alteration in atlantodental interval. It may either be manifested by facetal malalignment, or may even be manifested by understanding during operation by manual handling of the bones. So this concept we have labeled as central or axial atlantoaxial instability. Central or atlantoaxial instability means there may be instability which is not demonstrated. There may be instability which is not recognized by radiological imaging, but it is recognized by nature, and protective actions are initiated by nature in the form of Chiari malformation, in the form of basilar invagination, in the form of protective self-neural destruction which is called syringomyelia. Syringomyelia is a protection which is initiated to prevent cord compression by the odontoid process and to make processes that will make the cord float into the fluid of CSF. We have also identified that in such situations, particularly in cases with basilar invagination, there may be excessive fluid formation not only in the spinal cord, not only into the brainstem, but also around the spinal cord and around the brainstem, processes which we have labeled as external syringomyelia and external syringobulbia. We have also identified that there is not only shortening of the neck, but there is a shortening of the head. There is anteroposterior or transverse increase in dimension of the spinal cord and of the head, but there is vertical compression both of spinal cord and of the neck, which results in short neck and results in shortening of the posterior cranial fossa in vertical dimension, but increase in the anteroposterior dimension of the spine of the posterior cranial fossa and of the spinal cord. So this increase in anteroposterior dimensions results in excessive amount of CSF either within the neural tissue or outside the neural tissue. There is no evidence in our study that posterior fossa volume is reduced in a combined dimension, which is manifested by the fact there is a lot of excessive CSF spaces inside and outside the neural tissue, both in the posterior fossa and in the spinal cord. On the basis of my evaluation, I have come to very solid conclusion that foramen magnum decompression is a wrong operation. It is a counter-effective operation. It should not be done. Opening of the bone and removal of the bone and opening of the dura and dural grafting are potentially dangerous operations which are not only dangerous, they are counter-effective and should not be done for Chiari malformation and for syringomyelia. Atlantoaxial fixation is the treatment. No manipulation of the soft tissue should be done, no tonsillar handling, no arachnoid handling, no shunting. Any kind of manipulation of syringomyelia is a potentially dangerous operation, should not be done. They are protective. When this happens, when Chiari malformation is associated. Now I want to make a very big statement. When Chiari malformation is associated with bone malformation, and when Chiari malformation is not associated with any bone malformation, in both these situations, foramen magnum decompression is not an operation. Atlantoaxial joint fixation is the answer to this problem and should be done. On the basis of my personal experience, which is more than 35 years in this subject, and on the basis of this philosophy which I am saying before you, that atlantoaxial fixation or instability is the cause. We have done over 300 operations in the last several years. Beautiful results and remarkable, outstanding clinical improvement which no foramen magnum decompression can give in the immediate postoperative phase. Foramen magnum decompression might give you immediate postoperative relief in the immediate postoperative period, but in the long situation after 4 years, 5 years, this will certainly lead to recurrence of symptoms because the problem is not solved. Problem of instability is not solved. All reported results of foramen magnum decompression, the average failure rate is over 25% in the literature. The treatment of Chiari malformation and syringomyelia is now focused, is now defined on the basis of philosophy, on the basis of concept, and the treatment is atlantoaxial stabilization. Thank you very much.